But in this case, it does seem to be interesting, doesn't it? That here we can do something which saves money, makes patients better, that was your point, and gets them out of this, at least in inner cities, these combat zone emergency rooms, which really aren't set up to deal with this.
Absolutely.
I mean, where's the downside here? Is there a downside?
I think there is a downside when you think about giving an agent that is active this long in the body. You know, are we going to start seeing more and more issues with resistance and to a point where maybe they aren't, you know, as good agents down the road? So I think that's the worry, is there's still a bit of an unknown to having a drug that is going to stay in the body that long.
Okay, that notwithstanding, any downsides you see?
Well, I mean, yeah, I mean, I think that's a theoretical downside. As I mentioned earlier, I think that the risk of resistance development in gram-positives is slightly limited as compared to gram-negatives. But I think that this is one of the very first times that I can see where all interest groups are aligned. You know, as we mentioned, for the community, it will be much better for society to pay for less admissions, for the patient, obviously, to stay at home rather than being admitted, and for the hospital to avoid an admission that's unnecessary, particularly if it's a type of admission that the hospital usually doesn't get covered with the reimbursement. So there's really no reason why not to do that when you can do that. And you need to be responsible to put together a program to make it possible.
Well, this all sounds interesting to me, but I want to give you guys the last word because as is always the case in television, the clock sort of does run down. So before we go, I'm going to give each of you some dedicated time, we'll use a word again, a silo of your very own. And if there's one message that you'd like our viewers to take away, now would be the time to deliver that. Dr. Golan, why don't you go first?
Well, I would say when you care for a patient with a skin infection that traditionally you would consider an admission because of fever and leukocytosis and so forth, know that admission is not always the best choice for those patients. And now we actually have the way to treat them in an outpatient setting and give them an admission grade type of antibiotic course of therapy with the same success rate, but in a much safer and less costly way.
All right, Dr. Jones, you've got the last word.
Yeah, you know, I really think it comes down to 3 points for me. The first one is if you look at lipoglycopeptides and even some of these other new anti-MRSA agents, you know, none are going to definitively replace vancomycin, but I do think they all have a niche. They all have certain populations and a place in therapy. And I think going back to OPAT specifically, whether it's admission avoidance or discharging early, I think it's a great option to decrease length of stay to prevent admission. And then finally, I think it all comes down to 3 things. Selecting the right patients, selecting them early, having protocols and gatekeepers in place, and then finally, assuring proper monitoring and follow-up.
Well, that's just been great. Thank both of you for being here. You know, every now and again, if you stay in medicine long enough, you find something that sounds really good, that seems to work and makes really good sense. This is one of these times. You know, is it 20 years from now, will we be having a different conversation? Maybe other people will be having this conversation. But for now, getting people out of the hospital and treating them as outpatients, making them better, it all sounds great. This is interesting to me. So we'll follow this and we'll maybe have you back and discuss it some more. I want to thank you for joining us for this panel discussion as well. I'm Dr. Peter Salgo, and I'll see you next time.